Hello, mates. It's Rav. It's all about fertility today, and I've got a very special guest, Gabriela Rosa. She has a master's in public health. She has a master's of science in medicine, specializing in reproductive health. And it's a privilege to have her on the show because she's got an incredible live birth success rate of 78%. So, welcome to the show, Gabriela Rosa.
Thank you for having me.
Brilliant. Tell us a little about the Rosa Institute. I've been dealing with fertility patients for 25 years as a functional medicine doc and doctor of Chinese medicine. So I'd love to hear about the work that you're doing.
Yeah, great. Thank you. Look, I think our work, the way that it actually has come about is interesting because I never set out to help couples overcome infertility and miscarriage when everything else had failed, like that was not my intention at the outset. Yet, I think patients started to be referred to me that had really complex and difficult cases. And one time, this lady was referred to me that had been trying for 10 years. And I was like very skeptical of whether it would actually be possible to help her conceive. And I said that to her. I said, look, I haven't really dealt with this was like 15 years ago. I haven't really dealt with, no, actually, I think longer. Gosh, I lose track of time. I've been doing this work since 2001. So you can imagine it's been many thousands of patients, over those years. But she basically came to me a decade and a half ago or more and said, can you help me? And I'm like, I don't think so, but, you know, we can make you healthier. And if that helps to prepare you for an IVF cycle, because that was her thing, she basically was like, I just want to do one last IVF cycle. She had had multiple that failed before. And I said, okay, well, let's go and see. And we did all the things that we normally do, which is really getting very deep into what are the obstacles to optimum health. And she conceived, a few months after us beginning treatment, and that led me to start to really think about, okay, was this a fluke, or is there an actual codifiable process that is going to be reproducible? And so I had that thought for a while. And then another lady who had been trying for 19 years came to my clinic. And I was like, okay, this is either a sign from the universe or, there's something going on. And it turned out very different story, very different reason as to why she was infertile. But same kind of similar journey. She had had multiple failed IVF cycles. At this point, she was 44. So it was like, this is now or never. And I said to her, I said, look, I don't usually treat, because before these two cases, I was mostly treating women who had been infertile for a year, maybe two. And so when these two cases like rocked up at my door, I was like, okay, this is interesting, confusing to me about, how this is going to turn out. But it turned out that we did, then I had more of an idea because I started to really get very clear about, okay, what are the specific things that make a difference? And then, she went through treatment, had her baby, and I was like, okay, maybe we change the whole tact of how we
Mm.
approach this entire conversation. And I started to then only market or kind of call to service the people who basically had been infertile for 2 years or more. And so it turned out that after doing that, we ended up attracting people who had really difficult and complex cases, but we started to help them, and that grew from there, and then it turned out that the average number of years that people are infertile before they come to us typically is around 4 years. So
Wow.
it grew from me not really knowing, is this something that can really truly help, or is it just that we're really optimizing health, to really being something that actually can be an alternative for couples who don't wish to go down the IVF path or who are going through it without success?
Got you, got you. I mean, you've helped over 140,000 couples. That's a lot. You got a 78% success rate. That's absolutely incredible. Tell us about some of the limiting factors that people might not know. People go to the gynecologist and they say it's all fine, or they've been trying for a few months and say, carry on trying. And there's so many factors, toxicity, is the Babesia, Bartonella. What are the fertility houses or clinics missing that you guys think that you put your finger on? from toxicity to environment to radiation. Tell us a little bit of the things that you focus on that others don't.
I think that it's fair to say that we focus on the patient first.
Mm.
And I think there's a lot to be learned from understanding that person and that person's environment. Because we know very clearly that, unfortunately, our day-to-day environment, our exposures aren't necessarily the most conducive to optimum health, right? We know that there are many challenges that we face, even just from the food that we choose to eat, where we might be buying organic, but we didn't know that it was in the transportation of that product, it was contaminated. Or, there's lots of different things that can go on that we don't really understand or that we don't know, or that there is absolutely no way of knowing. So we work backwards from the outcomes, right? And we start to question from the symptoms that we are seeing, what are the underlying biochemical chain reactions that are leading to that result, that are leading to that outcome? So it's fair to say that, when somebody comes to us, the very first step that we take, and we take like a good 6 weeks to really dive deep into who is this person, and then we do that with both partners. We're not just looking at one side of the equation, because we know that 40% female factor, 40% male factor, and 20% embryonic factor. And really the only thing you have some influence over is the male and female factor. By the time you get an embryo, there's going to be very little that you can do short of optimizing the environment that it goes into beforehand to really optimize the chances of having a healthy pregnancy to term. So that's where the challenge begins, is actually figuring out, okay, well, who is this person? What are the types of what is the exposome of that person? Like, what are they actually involved in, even from
Mm.
a mental psychological perspective? Like, sometimes people have, it's not even so much about stressful jobs, but stressful lives that causes, a whole cascade of hormonal imbalances and nutritional deficiencies, and you name it. So we really we take the time. I think that what we do differently from IVF in particular is actually taking the time to really truly understand and properly diagnose what's happening before we jump into conception attempts. Because our patients, although the majority of them, the live birth rate of the program is 78.8%, but 47.7% actually conceive naturally. And this is when almost 50% of all of the patients who came into the clinic previously had failed IVF treatments, right?
Got
More
you.
than half previously had miscarriage and recurrent miscarriage issues. So really, then we have to disentangle, a lot of the things that are actually not going quite right in that person's biochemistry, to be able to figure out, okay, now that we understand that for
Mm.
both partners, how does that come together in a different way? And
I got
that's,
you.
that's kind of the crux of it.
But give us some specifics. I'm sort of maybe going to push you a little bit. Are you looking at like vitamin A, vitamin E, or you doing
We're
urine
looking at all the
samples?
vitamins, right? So
I mean,
we're looking at, okay, so in terms of like when I look at fertility, we have what's called the 11 pillars of fertility. And then from that, we're going at, you know, what are the nutritional status, diet, lifestyle, exercise, environment? What are the toxins in that environment? What are the toxins in their kitchen? Sometimes people don't even realize that their pots and pans, the being forever chemicals, is actually causing them
yeah.
infertility. We know that endocrine disruptors are rampant in our environment. So understanding where they're coming from and how they are impacting somebody is going to be really critical. So, like, to be very, very specific, the very first thing that we will always do is proper diagnostic testing. So that's going to range from, just normal blood tests that are much more in depth than what you would go to your local GP and get done, to stool, to hair, to, like, whatever it is that we understand from that person's situation is leading to symptoms. And if we're not sure, that's the first thing. It's like, okay, if we don't know what is causing these symptoms, then the job becomes very much of like figuring it out,
Yeah, I mean,
right? So,
you're a
and then we're going to
naturopath
use.
as yeah, you're a naturopath as well. So you're doing functional medicine as a basic start. Is that correct?
Yeah, absolutely. So I'm a naturopathic practitioner,
Yeah.
and from the perspective of treatment, we utilize a lot of naturopathic principles. But from a perspective of understanding what is creating those issues,
Mm,
we're using kind of orthodox diagnostic, kind of science-based tests
sure.
and investigations and all of those things.
But what are some of the tests? Like I see you wearing an Aura ring. Is that because now all your patients are going to look at heart rate variability and their sleep cycles? What is sort of the golden nuggets of the Rosa Institute that the other fertility clinics are not doing? If someone's listening and they've been to fertility clinics or they've been trying for a while to say, wow, here's a naturopathic physician, it's an online clinic. Maybe I'm missing something, or I've got to check for mold. Is it toxicity or mold? I mean, obviously you've got to treat the patient specifically with the symptoms, but there might have been some threads that you've seen that other clinics are missing to say, geez, maybe it's the pots and pans and there's an aluminium toxicity.
Steve,
What have you
it's
found?
it's really funny because most clinics don't look at any of these things,
Yeah, sure.
right?
That's why I'm
So
having you on,
if you
Rose.
go,
That's why I'm having you on.
exactly. So if you look at an IVF clinic, what does an IVF clinic actually do? They basically give drugs to the woman so that they can have more eggs, so that they can harvest that under general anesthesia, so that then we can get a man, give a sample in a cup and put those egg and sperm together and hope for an embryo, hope for fertilization. There isn't the first conversation about what nutrients you should be taking, or what food you should be eating, or what type of exercise of the prescription you should be doing, or whatever, right? So from a context of, unfortunately, how patients are actually treated through a
Yeah.
very broken system, that's essentially what happens, right? And so most patients who are experiencing fertility challenges, they don't even realize that fertility is actually a team sport.
Mm,
So looking at, like they don't even realize that maybe their number of one night stands that they had when they were 18 or 20 is actually contributing to their infertility today, right? And usually those things, even though they might have quote unquote everything looks normal in blood tests,
mm,
I mean, you see this all the time, I'm sure, when people come to you and they're not getting to the bottom of like what is happening with my health and what are the
mm,
things that I need to look at. They're basically, I see this, it's almost every day I see this example in my clinic. Somebody will go and they'll say to me, I have had 4 miscarriages, and I've had all the tests, quote unquote, all the
mm,
tests, right? And for fertility, mind you, there's 4 tests that a GP will order. It literally, they're looking at your hormonal balance, kind of, right? A day two, FSH, LH, AMH, maybe estrogen if you're lucky. Then they're looking at, are your fallopian tubes clear? And are you ovulating with a day 21 progesterone, which might not even be the right day for an actual progesterone test for a woman that has a lengthened cycle, for example, right? So they will go and do these things, and they literally will like results come back, haven't found anything in those tests. Oh, and the fourth thing that they will get done, if you're lucky, quote unquote,
mm,
is a semen analysis. How many patients over 24 years I have seen that have been infertile as a couple for more than 2 years who has never even had a semen
mm.
analysis? I
Got you.
cannot even count. So basically, what happens is, and this is part of my frustration with the system, right, is that patients will go, they will have these minimal investigations, and then they will basically say, everything is normal, just keep trying. And then you go and you look because, a GP may have been more careful or more cautious, whatever, and did a thyroid function test. You look at the TSH, the range for TSH is 0.5 to 5. We know very clearly that there is an increased risk of miscarriages from a TSH that's 2.3 and above. But what happens? Because it's within the normal range
Yeah.
of 5, they're just told everything is normal, just keep
Mm.
trying. And yet this woman has had 4 miscarriages.
Got you.
So it's like, there's so many different things. And this is why it's so personalized, because there isn't a one size fits all. When we approach a patient, really we're trying to understand what are the answers that we need, what are the questions? First of all, what are the questions we have to ask about this person to then actually understand what are the answers we're looking for? And that is a complex set of variables.
Mm. Okay, so you're doing advanced. Look, my audience is quite well versed in functional medicine, looking at very important factors like thyroid. And I mean, a lot of these thyroid specialists don't do reverse T3. They don't even know what reverse T3 is. So there's a
Or
lot
they
there.
say it's not necessary.
Yeah, they say it's not necessary, or vitamin D is not at optimal levels, it's just at normal levels. But so maybe just to end this off, is there anything specific that you've really found as being like a key test or functional medicine test, like a hair tissue mineral analysis or organic acids test or GI map test? Is there anything that's like, this has really helped my fertility patients that have been struggling?
Look, I think that when I look at it from the perspective of like all of our patients, we do hair mineral analysis for all of our patients,
Mm,
right? So we know that heavy metal toxicity is going to be an issue. But we also know that during a conception attempt phase, it may not be the right time to actually disturb those pockets of heavy
mm,
metal toxicity, because we know, like, I had a patient once who came to me. She had had 4 miscarriages, and I was like, okay, this is unusual. And that was one of the reasons as to why we started doing hair mineral analysis across the board, because she had had 4 miscarriages. We couldn't find anything major other than immunological components that were very basic. There wasn't anything that, really kind of prompted me to go, this is the cause or this is the reason. So I got back her result for hair mineral tissue mineral analysis and saw that there was like off the chart mercury. And I'm thinking, okay, this is not good. So then we actually did a serum to figure out, okay, well, is there something else how much is it really that we need to be concerned about? Do we need to do something about this right now? Or not? Because if it's not circulating, if it's in the hair and it's being excreted, it's not circulating in the blood, maybe we don't need to do something about that at that point, right? If, as we know, heavy metals, particularly mercury, will be very buried, very deep in bone, brain, kidneys, and if it's kind of like coming out in the hair, but it's not in the blood, we kind of go, okay, it's an issue, but maybe we don't do anything about it. Her levels came back at 40 times higher than the maximum 10 that you would expect in a blood test. And so we're like, okay, we can't just leave this. This is something that we're going to need to address.
mm.
And addressing it meant that we had to do medical chelation therapy with this patient for a year, an entire year of chelation. And so, because her levels are so high. And so basically what ended up happening with that is that because she was younger, she was in her early 30s, we actually had the luxury of time to be able to address it in that way. And, it took us 12 months of chelation, then another 4 months of waiting so that she could try again. We then finally got her to try, conceive straight away, pregnancy to term. She had 4 babies through the
Wow.
program thereafter. So clearly it was her issue, it was a major issue. But in the grand scheme of what I see, heavy metal toxicity is a small percentage, of all of the people that I
Yeah.
see. But clearly for her, it was the one thing that we needed to address, because if we didn't, we would be in a situation of just her continuing to have more and more miscarriages. So what I mean by that, and what's important here, is actually to understand that, okay, there's a gamut of tests. And as you know, there's thousands of tests that you can do that will cost you millions of dollars if you do all of them, literally, right? And so you have to be really selective as to what's going to be important. But a hair tissue mineral analysis, which gives us a lot of information about nutrient levels and excretion of heavy metals, toxicities, etc., is going to be one that's cheap and valuable. So we have to weigh that up in those ways,
Yeah.
because organic acids, for example, super helpful, but for some people, if we're going to address those biochemical pathways anyway, do we test? Because if we're going to be using however much, $1,000 to be able to do a comprehensive panel, and we know that we're going to be addressing that, is there a point to test if we're just going to address it? So we then have to choose, because in fertility, we have to choose what is going to be the biggest bang for your buck in terms of every investigation that's done and the time frame, because we don't have unlimited time. That's the biggest issue. With this lady, even though we found these issues and we had the luxury of being able to address them, for some people, we do not. Like, some people come to us, they're already 40.
Yeah.
Like, if we're going to spend a year of chelation therapy, that's never going to work. So then we have to do things in a very different way. And that resourcefulness to understand what is actually going to be the minimum effective dose of intervention to outcome is really where the magic happens, because we don't want to be doing things unnecessarily, and we have to really speed things up for most of the patients that come to us.
All right. So if you're listening out there or you're watching on YouTube, understand you probably don't even know a lot of these tests, but it just shows you that if you've been struggling, there's a lot that can be done that your fertility specialist might not be doing. So just bear that in mind. Things like organic acids possibly, or things like hair tissue mineral analysis, or, a GI map test, or looking at mercury levels. So I think bank that and share the episode with people that are struggling, because it seems like more and more people are struggling. Maybe you can give us the infertility rates. I've been in this sort of treatment protocol for a long time. Is it dramatically increasing in modern day cities? And I'm not talking about the rural sides. In modern day cities, couples, what is the infertility rate in general?
1 in 6 couples is infertile, and 3 in 4 pregnancies and a miscarriage. So we have to understand, of course, fertility rates across the globe are actually declining, and we're having an older population and so on, even though we think that, okay, the population is expanding, but it's actually not being repopulation isn't happening at the same rate that people are actually living. So, there's some estimates that within 20 years, we will have population decline across the world, really. So I think that, the challenge that we have, and I think that this is looking at it from a public health lens, is that in public health, really what's interesting for most governments and healthcare systems around the world is to do the absolute minimum for the biggest number of people. Okay. So when it comes to fertility, at the stage that we're in terms of population level at this point, it's really not something that's seen as necessary, because what happens is that people are still conceiving without trying. And the majority of couples in kind of like, your general population at peak fertility conceive within 3 conception attempts. And many, it's that kind of like, oops, I wasn't trying, got pregnant. So what happens with couples who are then struggling to conceive is that you see limited funding for access to treatment is the norm around the world, right? And so we don't have the focus and the resources when it comes to actually treating infertility that couples really deserve. And this is why they go to their GP, and there's like, two tests, 3 tests, maybe 4 are done, and they're just told, everything is normal, just keep trying. Because at this stage still, there isn't the understanding and the focus that, okay, actually, if we don't address population health across the globe, we are going to end up being in a situation where we are going to struggle as a civilization. So it's a tough conversation, particularly this day and age where climate and climate change and population, is expanding and burgeoning. And the burden of an older population is really being felt across the globe, particularly with non-communicable diseases, like obesity, cardiovascular disease, cancers being on the rise. All of that makes fertility be a conversation that really has to take a backdrop, because we have so many challenges in terms of the healthcare system that is not coping, that this is what ends up happening. But certainly from a looking ahead perspective, I think that we do need to do more, and there needs to be better interventions that are going to also optimize and sustain health and quality of life in the
But I
long
mean,
term.
is that 17% or 1 in 6 is about 17%? Is that for modern day couples or is that across the board? Because it just seems, my practice, over 25 years, more and more people are struggling. I think the biggest sort of problem is age, and age causes a lot of other issues. I don't know what the ideal age is to fall pregnant, but if you look at it, is that a statistic of a global level, or is it a modern
Yeah,
day
it is a global
city?
level. It's a
Yeah.
it's a global it's a global level statistic. But the thing about it, and the reason that what you're saying is true, is that couples are leaving it much later to have babies. So it's not that we're having more problems, is that 20 years ago or 40 years ago, which is 2 generations ago, people were having babies at 19, 20, right? Now people are focused on their careers and building their life and all of the education and you name it. And they're leaving reproduction to a much later stage, which makes it more difficult. You
Yeah, I
see,
got you.
my mother had me when she was 21. I had my children, my first child when I was 33.
Yeah, no, I'm with you. I got you. So, what are the two tests? Are you looking at an AMH? Someone's listening now and saying, listen, I'm 25, I'm still studying, I'm trying to build my career. From a female perspective, are you looking at ovarian volume that they should go in? I mean, some of even my corporate executives are now doing, they're freezing their eggs. I mean, someone's listening and saying, okay, I might only have children when I'm over 30. What I do right now from a female perspective, and then from a male perspective, do they go for a sperm analysis, or what should people do if they're listening now?
Yeah. So for men who want to reproduce later, and of course, male fertility also declines with age, but it's at a much slower rate than female fertility. And so I think always doing a semen analysis early is going to be very helpful because it's going to really be able to support the understanding of what might I have to do in the future, right?
Sure.
So, and of course, in some instances where there might be a sperm reduction, then we start to look at why that might be the case. Some men these days, in particular, with endocrine disruptors being rampant in the environment, right? Some men are being affected in that way, and so menopausal effect in the
Mm.
andropause for men is actually a real issue. Which brings me to the fact that if we have testicular failure, then it might be that we have to also freeze some sperm. And it may also be very helpful, to be able to understand, okay, if I am 30 now and I have good quality sperm and I know that I want to father a child no matter what, freezing and banking sperm is actually a really cheap and very easy thing to do,
Mm.
right? And so that's something that I would highly recommend men who know that, okay, this is my future, this is what I want to do. They may not ever use it, right? They will kind of use it as almost as an insurance policy, but it's there if it's needed, right? Women, as always, for women, everything is so much more complicated, right? And so much more complex. But for women, what happens is that we're still not at the level of technology where you freeze eggs and you end up with a baby at the end of that process, right? So there is a possible chance, insurance policy style, of freezing some eggs and still being able to end up with, a baby. But the reason that this whole egg freezing thing started to begin with was for girls at puberty to be able to freeze eggs if they had to go through chemotherapy. By the time you get to 30, your egg quality is not what it used to be when you were a teenager, right? And so what happens is that even if you use vitrification for egg freezing, which is the best approach for egg freezing in 2024, you still end up with a situation of the cytoplasm, the watery part in the egg itself, before the nucleus, within like outside the nucleus, it doesn't defrost very well. So what happens is that, let's say you are able to freeze 5 eggs, right, which is not very many. And typically, if you go through an entire IVF cycle to collect eggs, if you collect 10 eggs, that's going to be wow, that's amazing, right? And of course, if you have PCOS, if you have, other conditions, and if you're hyperstimulated, which can cause death, and therefore we
Mm,
don't do that, right? We have a situation where you might have more eggs, but they might not all be mature enough to be able to actually be defrosted and end up in a
mm,
pregnancy anyway. So more eggs doesn't necessarily mean more embryos
yeah.
or, the possibility of more babies, although the lesser number of eggs that you have frozen for use at another time, the lesser chance you have. Let's say if you do have 10 eggs that are mature and, essentially a good quality and they were frozen at age 30, you might, upon defrosting those eggs to fertilize them, only end up with five, only end up with two. You don't know. And out of those, you don't know how many are actually going to fertilize with sperm, right? And so, one possibility and one alternative for women is freezing eggs. Obviously, the first alternative is having children at a younger age, which is not for everybody. Also, sometimes people haven't found their partner or they have, there's other constraints basically. But obviously, trying to have children earlier is going to be the first thing. The second thing is freezing eggs. The third thing, which might be more effective in terms of hard outcomes, is actually freezing embryos. So, if you are in a relationship that's stable and you think that you want to reproduce with this person, you go and you freeze embryos today for use at a later date. The cautionary tale here is that a relationship might be great today, but you may not be together in 10 years from now. And I've seen this happen many times in my clinic, where couples decide that, yes, everything is great today. We want to go, we want to freeze some embryos, and then they break up or they're no longer together. And then the woman has no more opportunity to have a child. She wants to use the embryos. The man refuses, and she cannot. The clinic will not release those embryos because those embryos are not only made by her. So that becomes a really challenging situation, right? And vice versa is also true. Like, you might end up with not being with a person and the previous partner wants to use the embryos. What happens then?
Sure.
So if you have agreements, like for example, as part of relationship agreements, people can actually elect to have these types of divorce agreements as well. And this is something to consider. If you think that, okay, things are great now and we want to do this, knowing that if we're not together, decide in advance what would happen,
Sure.
right? And that I think makes it at least clear to
Got you.
everybody going in how to do this. But
Mm,
yeah, I think those are some of the things that I think people need to consider because it's, just like IVF and all other assisted reproductive treatments are not a magic bullet, right? It's not a silver bullet. It's not just something that you're going to do it and
mm,
absolutely is going to work. Freezing eggs and having that entire process go on is also not a silver bullet. I think
yeah.
that that's an important consideration.
But if someone's listening and they're female now, should they go and check their AMH? Should they do some blood tests? Should they get an ultrasound to have a look at the ovarian volume? What are the latest sort of data points that someone can say, okay, I'm in generally good reproductive health?
Yeah, so you definitely want to check your day two FSH levels, your follicle stimulating hormone. That should be under 10, right? You want to look at your LH. That should be no, it shouldn't be double your FSH because then you know that potentially you could have polycystic ovarian syndrome or some other issues. If it's too diminished on that day, you might have premature ovarian failure for the LH. But for the FSH, if it's too high, that also indicates the same thing. So your AMH levels, if they are too low, they're going to indicate that the ovarian reserve is not what it needs to be, i.e., women are born with all the eggs we'll ever have, and we kind of lose them over time, some by attrition, some by ovulation, some, basically just stay there but don't have enough fertility potential. And so what happens is that women these days going through menopause, say at 45, 50, the process of perimenopause begins 5 to 10 years earlier their menopause, i.e., the end of your reproductive life or your reproductive ability. So, what happens is that even in that 5 to 10 years before you stop having periods altogether, there can be major hormonal imbalances, but they can also happen at a much earlier point. Like I had a patient once who was 21, came to me for a naturopathic consultation. This is many years. I don't do naturopathic consultations now, but many years ago. And basically, what was interesting about her is that she was just saying to me, I just want to make sure that I'm healthy and reproductively speaking, that everything is normal. So we went and we did FSH, LH, AMH, day two, did an estrogen baseline, did her 20, like 7 days post ovulation. She had a regular cycle, 7 days post ovulation progesterone. Results come back. Her AMH was less than 1. Now, with an AMH of less than 1, we know that that typically happens around 40, 45, thereabouts, 43 onwards. But for her, it was happening at 21, which means primary ovarian insufficiency. And of course, from that perspective, ovulation failure is going to be, and entering menopause at a much earlier age is going to be very likely.
Mm.
So she had to make a decision. What do I do now? And that was part of our conversations. It was like, okay, what is it that we're going to do here? Are we going to, and she was in a relationship. So are we going to freeze embryo? She also wasn't ready to have a family. But she's like, okay, if my choice is having babies now, early in my life, when I'm not actually really that interested, but it's kind of like having them or not having them at all, and or spending thousands of dollars to freeze embryos and, go through IVF procedures without knowing if that's going to work, what do I prefer? So she actually opted to go and have children early. Right, which was not really in her plans, particularly not. She had just graduated from university. She was just starting her career.
Mm.
And it really wasn't something that she had like set out to go, yes, I want to have children this year. But it
Mm.
was something that we found that really meant it that she had to make those decisions pretty clearly, very
Mm.
quickly.
Got you.
So, like doing those basic tests at this stage, I think if you don't have any reason to believe that you have reproductive challenges, doing those basic tests is going to be enough just to have some visibility of what's going on within your body, right? Like I was diagnosed with polycystic ovarian syndrome at the age of 18, and it was really by doing these tests. I mean, my periods had stopped, so I was like, okay, why?
Yeah.
Right? I wanted to find out what was going on, but then it was really kind of going, okay, well, let's just do some basic testing and let's see what's happening. And of course, from the basic testing that I did, it was very clear that that's what it was. So then I was able to prepare myself and my body. I knew that I wasn't in a situation where it wouldn't be absolutely never be able to get pregnant if I didn't do it right there and then. But I knew that I would have to be more careful and
Mm.
cautious about my choices in terms of fertility, even from a day-to-day lifestyle choices, right? Because with PCOS, you have increased insulin resistance. In most cases, you have, prediabetes, diabetes being a consequence in the future of these issues. And so for me, it became something that really made me a whole lot healthier in my mindset and has certainly served me, later in my life. But and when I decided, because I was already aware and I was already kind of preparing my body in the ways that I needed to, when I decided to get pregnant, I literally conceived with my first child, first time of trying, and my second child, second time of trying,
Yeah.
right? So it was because I knew what was happening and I had then the tools to be able to address it, that it happened so easily. For most women with PCOS, which is 15% of the causes of infertility in women, is actually to do with PCOS. They end up being told, no, you have to have these ovulation induction drugs, or you have to go into IVF because there's nothing you can do. Well, the reality is that there's a lot you can do. Even
Mm.
the doctor that diagnosed me, he literally, says to me, call me in 2 days, I'll give you the results. And over the phone, he literally just says to me, you have polycystic ovarian disease. And I'm like thinking, am I going to die?
Mm.
Like, what does this even
Yeah.
mean? Because I was so young and I didn't have any idea. And he goes, no, you're probably just never going to have children.
Sure. Wow.
I'm like, Oh, okay. That's really a lovely way to be told that piece of news. So,
Absolutely.
but long story short, it actually got me to where I am today.
Mm. But I
And I
think the
guess it's
key
not a
is,
bad place.
you stopped, your period stopped and you decided to investigate. I mean, when should parents start looking at their daughters now, especially, because I've just seen more and more young teenagers firstly going to precocious puberty, like at the age of like 8 or 9, firstly, and then secondly,
Mhm.
they've got painful periods and irregular
Yes.
periods. And,
Yeah.
so it's becoming more and more problematic just because of the hormonal imbalance. If parents are listening now, and their kids are struggling with their periods and they're painful, should they investigate or start putting things in place just to optimize gynecological and hormonal health?
Yeah, 100%. And, one of the really important things that I think people need to be aware of is that just because something is common, it doesn't mean it's normal. So, just because you have, most women complain of period pain or of irregular cycles or whatever it might be, right? It doesn't mean that it's normal. And I think that that's a very important takeaway message from this entire conversation is even, right, from a fertility perspective, because so many times patients will hear exactly that. Oh, everything is normal, just keep trying. Hang on a second. What's normal is I have sex, get pregnant, have a baby, and we're no longer having this conversation. If that's still happening, or if we want to prevent it being a problem in the future, then we need to start asking questions now because fertility, a lot of times we think of fertility as something that we deal with when, somebody's married and have had their children,
Exactly.
have had their careers or studies or whatever. But the truth is that if a girl is having imbalanced hormonal levels, if they're having painful periods is a great example of, a silent reproductive condition, endometriosis, that can actually stop a woman's ability to have children altogether and carry a pregnancy.
Mm,
So understanding why those things are happening is definitely going to be important. Now, the same principle applies here. If you're going to treat anyway, there might be a question mark around testing because, endometriosis, for example, the main way in which you can actually really get a proper diagnosis is to going through a laparoscopy, which is a surgical procedure. So you might not necessarily put a 14-year-old girl through a surgical procedure to see if endometriosis is happening unless the period pain is extremely severe, right? In those cases, then it may very well be that, and some girls they become incapacitated
yeah.
during their periods. That is absolutely not normal. And
Mm,
understanding that there is so much that can be done from a lifestyle perspective, diet, increasing omega-3 fish oils, high dose, all of that magnesium, basic simple things, but that can be extremely effective for
yeah.
managing period pain and cramps and all of those things. There is a lot that can be done, and I think people should come to you to really look at those things because that's such an important
Yeah.
thing to be able to really ascertain very early on in a woman's menarche, when we
Mm,
start to get periods, because otherwise we will go and deal with silent problems all the way
mm,
through
yeah.
to
I'm
when
got
you're
you.
then deciding that you want to have a child and you can't.
Yeah, and what's your view? Because most like parents will take their daughters to the gynecologist and they get put on the contraceptive pill. What is your view about that? Because I mean, it's just something that's happening more and more.
Yeah, look, I have to say I'm not a fan. And I'll say that because I think that a woman's ability to know her cycle and to be able to, as a result of that, prevent pregnancy if necessary is really paramount. Right. The reason that I actually discovered that I had PCOS at the age of 18 was because I had this thought as I was about to start studying naturopathy that, I actually want to be in tune with my body. I want to know what's going on. And I had been on the pill for 1 year, and I was like, you know what? I don't want to deal with the consequences of this in the long term in my life. And I want to know what my body's actually doing. So I stopped the pill, and that's when my period never started back. Right. And that's one thing that happens often, like the oral contraceptive pill, and there's lots of evidence around this. It actually can trigger these underlying reproductive conditions like polycystic ovarian syndrome. So, am I a fan of putting young girls on the pill? Absolutely not. Am I a fan of them getting pregnant accidentally? No. But what is it that are the alternatives? Well, I think education, right? Conversation around these issues, helping a girl understand that there are ways to, through tracking her cycle and understanding her own fertile windows and fertile cycle. Because if you think about it, you put somebody on an oral contraceptive pill, or worse, Depo-Provera, for 3 months of, suppressing hormones and all of that. Early on in that kind of, establishment of the hyperpituitary, hypothalamic pituitary ovarian axis, all of a sudden you're putting a stop to what the body is actually going to start learning how to do, which is to cycle, right? And then you end up with a situation where you get off the pill or depot or whatever 10, 15 years later, and you'll never get your cycles back, or your body is in a mess and it's not doing what it needs to
Yeah.
do. And then you wonder, oh, could it have been? Yes, it could have been,
Yeah.
right?
I
The
got you.
things that you did
Yeah.
beforehand. And so part of it is, and I actually at the age of 18 decided to start tracking my own cycles. I used it back then, we used just, thermometer and paper and pen on paper charts. These days, there's lots of great apps, no conflicts, but there's a one called what is it? Cycles. Natural Cycles is one that actually I really like. Actually, I think it's the one that they use with the Aura Ring these days. So there's Natural Cycle. There's so many of them. Like just Google and you'll find so many different apps that you can use that will measure your temperatures, and you can input whatever app you can use for fertility. For trying to get pregnant, you can use for contraception. And I know that Natural Cycles, when they first came out, what interested me about them was the fact that they had done some studies based on their technology and looking at the predictive model that they had built. And it was the success of contraception through using their app was the same as the pill.
Wow.
Right. And so, yeah, so it can be that effective. And so that's why I think that it's so much more beneficial going on in their own bodies by using the right tools rather than suppressing symptoms, whatever symptoms they may be. Now, the caveat here is that if somebody has, for example, severe endometriosis at an early age, it's going to be much worse for them to continue cycling than it is to suppress their periods and then get them to cycle artificially if necessary down the track. So in certain aspects of reproductive conditions, then we may have to have a different approach, right?
Mm.
We may have to nuance those recommendations. But in the general kind of population across the board, it's much better to know what your body's doing and allow it to do what it needs to do naturally than to intervene.
Got you. Okay, we're coming to the end of the show, and I want to give people some takeaways, what they can do. What do you think the three most important things part of life, whether it's nutrition, exercise, sleep, are the most important with regards to fertility?
There's only one thing that I recommend my patients to do, or people who have that question.
Mm.
Act pregnant now to get pregnant later. What does that mean? Anything, and I say this to men and women, right? And I know that the men visualizing themselves being pregnant can be very challenging, but like indulge me for a moment here.
Mhm.
um, let's say that you were right now able to gestate a child and you had your baby inside of you and you were growing it right this minute. What are all of the things that you would absolutely start doing or would absolutely stop doing if that was the case?
Mm.
Well, right now, within everybody who might be wanting to get pregnant, there is already 50% of that equation going on, right? You already have 50% of your little baby inside you right now, whether it's the sperm, whether it's the egg. So taking care of those cells like you would a baby is essentially the one thing that people really need to start doing right now. Because by the time you want to get pregnant, that's already too late. Right, that's already going to have a whole entire lead time to optimizing those cells if that hasn't been done yet. Because the egg, for example, has a 1 year lead time from primordial follicle, which is the follicles we're ever born with, to primary follicle, which means that, if you're going to ovulatory follicle, sorry, which means that if you're going to be wanting to improve egg quality, already you are looking at improving that over a long period of time. It's not just going to happen. Of course, you can improve the first stage and the second stage, but in the grand scheme of things, you are having to look at adding time to the equation. So if you start to do those things now, by the time you actually want to try, you'll be ready.
Got you. Brilliant. Okay, Gabriela Rosa, where can people find you? I know you've done consults in over 110 countries. That's incredible. So well done to you. Sounds like your Rosa Institute is doing well. So maybe you can just give some links, and also, do people just apply on your website to consult with you, or what is the process?
Yeah, so basically they can find me online. So Gabriela Rosa, Gabriela Rosa, Gabriela Rosa, or they can go to my website, which is fertilitybreakthrough.com. And in there is we always assess cases before we take on someone. So the way that it works is that they would speak to one of my clinical assistants to figure out if moving forward would be something that would be ideal for them, and the process is free, so they can just go and request a complimentary consultation through the website.
Brilliant. Okay, last thing that I always ask almost every guest is just give a message of hope with regards to fertility, because there's a lot of desperate and despairing couples out there that have really struggled for a long time. And in my view, the rates of infertility are really much higher. So give a message of hope.
I think the biggest message of hope I can give people is find my book free online. Right. It's Fertility Breakthrough, Overcoming Infertility and Recurrent Miscarriage When Other Treatments Have Failed. And it's available free on Spotify and YouTube. And the reason that I say that is because there is so much you can do. And if you know what are some of the factors that are getting in the way, if you already understand the places of influence that you can exert in your own situation, you're going to be way ahead of, the curve when it comes to the success that you want to create. So know thyself, get a copy of the book free online, and go from there.
Brilliant. Well, just want to declare favor and blessing over you, Gabriela. You're doing incredible work and helping so many patients. We've had our own story of 10 years of infertility for our second child. So well invested, seeing patients for over 25 years that have struggled with fertility. So thank you so much. And we'll send as many people as we can your way, because I think you're looking at it through a totally different eye. And I think you're absolutely right. People are not investigating the different parts of their life, like the toxicity, like doing proper functional medicine, optimal tests, and that. So well done to you. And yeah, where you based? Hopefully we can meet one day.
I'm in Boston at the moment, but
Okay.
I'm typically based in Sydney, Australia. But I've been
Okay.
living in Boston for the last 3 years as I finished my doctorate.